So we're going to talk a little bit about wound healing and limb preservation. And I agree with Dr. Hanau that I think limb preservation is actually a much better term than limb salvage. Salvage sounds like a store you go to buy things that nobody else wants. So we're going to talk about arterial ulcers, and you can see from this slide that arterial ulcers don't appear like other ulcers. A lot of the wound care in arterial disease has to do with keeping the gangrene dry until it auto-amputates, or there is an amputation done surgically, and then you have to try and heal the wound. As you can see on the slide on the far right, this woman had an arterial ulcer that we were able to take care of, and she did eventually heal it, but a lot of them will present like these other slides that you see. The guy on the right had a FemPop bypass, which used to be the most common vascular procedure. And I don't think there's people in here look like they're 12 years old. I don't even know if they know what a FemPop bypass is anymore. So it's changed a lot. And I can tell you that having worked within vascular surgery and people who were innovating and doing all these incredibly new techniques back a long time ago, it's had the biggest impact on wound care of anything else. I know at UCLA they had this patient that was kind of archetypal. They called it a Debbie patient, a Debbie lady or a Debbie man. It was this older person, multiple comorbidities, not a candidate for amputation, not a candidate for a bypass. But they had an arterial ulcer and rest pain, and they're 90 years old and they're in miserable pain. So they did what they called a tweak angioplasty, to give them enough blood flow to heal the wound and get them out of rest pain. I mean, how great is that we can do that now, that we can take care of these patients with such a simple procedure. And these guys are fabulous at it. So when I started wound care back in the Crimea, we had, I think, duct tape and baling wire and iodine and sugar. And wound healing was mostly in the purview of nursing staff, which it kind of still is, but there really wasn't a lot of knowledge about how do you take care of these wounds and what's actually happening in the wound bed. And over the last 15 to 20 years, there's been just an outburst of research. So we have a much better understanding of what's happening in the wound bed, of what's happening biochemically in the wound. We still have a long way to go before we know everything, but we have such a much better understanding of what's actually happening. And these two doctors, Dr. Sibbald and Dr. Falanga, were two of the people who initially came up with a lot of the guidelines that we use now in wound care. And they coined this phrase, wound bed preparation, which I really like because it talks about patient-centered concerns as well as the actual physical care of the wound bed. And patient-centered concerns is one of the most important things in wound healing, no matter what the etiology is. You have to understand, do they have the cognitive function to take care of the wound, to remember what they're supposed to put on the wound, to be able to take care of themselves? Do they have the family support? Do they have the financial ability or the insurance coverage to pay for the dressings that we're using? What do they do all day? Do we need to somehow adjust their wound care and their edema care or their offloading so they can work? Because not everybody has the luxury of being able to take a week off to offload or staying in bed with their legs elevated. So we have to take all those things into consideration, and that's all a part of wound bed preparation. So the other part of wound bed preparation is to prepare the wound for healing, or in many, many cases, to prepare the wound for some of the advanced technologies that we have available to us now. So if you look at the wound healing cycle, we now understand that the wound bed in a chronic wound is stuck in the inflammatory or proliferative phase of healing. And if you have some of these things such as repetitive trauma, as in a diabetic ulcer, or somebody who doesn't feel their feet and their shoes are rubbing, or pressure ulcers, local tissue ischemia, necrotic tissue, heavy bioburden, tissue breakdown, all of these things elicit the inflammatory response. So you have elevated matrix metalloproteinases, which tend to those are the inflammatory cytokines that actually break down the bacteria, etc. But their other job is to block the growth factors, which, that's not a great thing if you want the wound to heal. But then you also have a decrease in the tissue inhibitory matrix metalloproteinase inhibitors, which their job is to block the MMPs, but you don't have enough. And so you get this chronic inflammatory cycle with degradation of the extracellular matrix, with degradation of the growth factors, release of pro-inflammatory cytokines, and so it just perpetuates itself. So the wound healing is aimed at breaking that cycle and getting the wound to progress on through the phases of healing. So one of the things that the doctors that I talked about before, Dr. Sibold and Falanga, came up with was this acronym TIME. And I like this because it allows us to explain wound care in an organized fashion. And T is for tissue, I is for infection or inflammation, M is for moisture, E is for edge of wound. And all of these are important. And none of them should take precedence over the other because they're all very important in wound healing. Tissue, meaning that you need to get rid of the necrotic tissue, except in arterial disease. So one of the problems that I see frequently, and I have seen in my 20-something years of wound care, is people like to debride gangrene because they can't tell a difference between gangrene and an eschar. And even if a wound has an eschar and it's not gangrene, you're very careful to debride that because you do not want to make a wound that you don't have the microvascular perfusion to heal. So arterial wound care is very different in that manner. You know, you have to be awfully careful about how much of a wound you are creating. The various kinds of tissue debridement, I've got obviously sharp with the number 15 blade at the bedside, surgical debridement, hydrosurgical with the Versajet, autolytic using a dressing that allows the body to take care of the necrotic tissue itself, biotherapy, which is maggots, which we've used intentionally and unintentionally frequently. We have mechanical debridement, which is whirlpool, which nobody uses really anymore, and wet to dry dressings, which I hope nobody uses. I'm not going to ask for a show of hands because you'll be publicly ridiculed if you do that. We have so many other things that are available that are so much better than wet to dry dressings. Infection or inflammation is what I just talked about with that other slide. There are many ways to control the infection and inflammation. With inflammation, there's dressings that actually block the MMP actions, the matrix metalloprotease actions. There's one by Cystogenics that's called Prisma, which is probably the best on the market. They do have a lot of research that shows the efficacy of this product, and we use it a lot. It's oxidized reduced cellulose, and it absorbs the inflammatory factors and gets them away from the wound bed. Some of the collagens will say that they have MMP inhibition, but I haven't seen a lot of evidence as far as actual studies that show that. I think they're just riding along with the Prisma. But there's ways to reduce the inflammation, but one of the best ways to reduce the inflammation is to get rid of the high bioburden. You know, a wound can be critically colonized. In a chronic wound, you can have just this mass of polymicrobial things, but the wound isn't actually infected. It can be critically colonized, and at that point, you can treat it topically with some of the silver dressings, with iodine, with some of the other topical antimicrobials that are available, and allow it to get out of that inflammatory phase and progress on to the proliferative phase. Moisture balance is really important. Theory of wound healing. If it's wet, dry it. If it's dry, wet it. It sounds simple, but it's really not because wounds are so dynamic. So Dr. Tringrove, I think in like the 1970s, did this really great study looking at acute wound fluid and chronic wound fluid. And chronic wound fluid is full of the inflammatory factors and not full of growth factors. And the reason that that's important is that if you leave those inflammatory factors sitting against the wound bed, you're going to make the wound worse. So you need to, and part of the moisture balance is to get that moisture away from the wound bed. So a lot of the dressings now have what we call diaper technology, like you suck the urine away from the baby's bottom. It pulls the wound fluid away from the wound bed and allows the wound to continue through without the inflammatory factors interfering. If the wound is dry, we need to keep it moist, so there are various ways that we can do that. And there's just a plethora of wound care products on the market, and some of them actually work. So, and sometimes it's really hard to figure out which product do you use because there are so many. But these are the three things that are most important when you're talking about wound care in any wound. And then when you get to the edge of the wound, non-advancing, there are so many things that we can do to fix that. And that's what the main focus of my talk is going to be. So the first thing I want to talk about a little bit is some pharmacologic management, because it's really kind of important. The first thing I do, if I have a patient with any degree of arterial insufficiency, is I put them on cilostazol. Cilostazol or Pletol was approved in the 1990 something for claudication. It effectively increased walking distance by 33% reliably. And it did that because it's a phosphodiesterase 3 inhibitor. And it does all these yada, 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 yada things, which you can read there. But effectively what it does is it causes microvascular vasodilatation and increases the perfusion. They've actually done some studies with TCOMs that show that it does actually increase perfusion. Not hugely, but enough to elicit some healing. I had a patient I put it on last week who was in significant rest pain. I put her on the Pletol. I saw her this week and her pain is much better. She can go actually for 24 hours without pain. So it does work. The most common side effect is GI, so I have them take it with food. It can cause some orthostatic changes, but not significant, so we have to be careful with that. It has a black box warning for heart failure. There have been some studies looking at using it in wound healing, but they're mostly just case reports. They did their research with the drug to get the FDA approval in claudication, so the pharmaceutical company has no reason to do anymore. One of the other things that I used to use was Revatio, which is primarily for pulmonary hypertension, but I noticed my patients with like scleroderma, if they have pulmonary hypertension, the doctors would put them on Revatio or Tracleer or Bosartan or something for pulmonary hypertension, and the wounds would get better. And so Revatio is sildenafil, it's Viagra, but it's 20 milligrams 3 times a day. The orthostatic effects are much, much greater, and there is that risk of blindness, and then there is that other thing that happens with Viagra. So it's Easter's coming, and at our church, the minister called up the children for this to ask them some questions about Easter. Sorry, I have to tell this joke. So they're all sitting there, and she says, they're talking about Easter, and she goes, Davy, so tell me about resurrection. What do you know about that? And he says, well, I don't really know what it is, but I know that if you have it for more than 4 hours, you should call your doctor. And so we have to just mention Trentol or methoxyphylline. This was improved, like back in the 1700s for claudication. It never actually worked, but I still see patients referred to me that have been put on Trentol for claudication. It's a good drug for venous disease with somebody with really significant venous hypertension. I use it quite a bit. It's a rheologic medication, and it decreases blood viscosity, but it allows the red blood cells to deform and kind of scoot through those little capillary beds or the arterial beds in a much easier fashion so that you can get more blood there, but it does not work in arterial disease. So now let's talk about some of the more exciting things that are happening in wound care. So the first thing I want to talk about is the MIST, the ultrasound MIST. This is a low frequency ultrasound in the kilohertz wavelength, not the megahertz, which is what's used for diagnostic and other therapeutic. So this works with the saline. You can see the little applicator there. So there's a saline mist that carries ultrasound waves, and it allows the penetration to in the skin about a centimeter deep. And what happens inside there is there's 2 things that happen. You get acoustical cavitation is what it's called, where it makes these bubbles, and the bubbles oscillate in the cells, and that oscillation causes cellular disruption. So you actually disrupt the bacterial membranes. And the other thing, you get microstreaming, which causes fluid in the cells to circulate, and that circulation also causes some cellular activity. So you get a change in the leukocyte adhesion, you get increased growth factor production, you get increased angiogenesis, you get keratinocyte activity. There's all kinds of things that happen. It is approved by Medicare 3 times a week for 18 treatments and more if it works. A lot of the other insurance companies approve it now. It removes the barriers to healing. It reduces a wide range of bacteria. And somebody did a study looking at the biofilm on a wound bed. And biofilm on a wound bed is really hard to get rid of. Even with debridement, it comes back in like half an hour. So with this particular treatment, the measurement of the biofilm on the wound bed before the treatment, and a week later, it was still 50% less than before the last treatment a week ago. So this is one of those technologies that we have that actually impact the formation of the biofilm and the bioburden on the bed of the wound. It also stimulates healing with increased vasodilation and angiogenesis, growth factor release, and increased collagen deposition, and it's all non-contact. So this is a slide that shows the evidence. We really don't have a lot of technology that we use that has this much evidence behind it. Even the silver dressings that are just rampant, all of their research is in vitro. Very little, there's no randomized controlled trials, good ones, looking at silver versus other things. There may be one or two, but the evidence base that we usually need for wound care, for what we do in healthcare, in anything, isn't really there in a lot of our products. But this is one of the technologies that we have that has so much evidence behind it, and people are still so slow to accept it. And insurance companies especially, it's still experimental. I'm like, look, how can this be experimental? What are you calling experimental? So this is one of those things that we really have to push for. This slide is looking at perfusion up to 10 minutes after a treatment with the laser Doppler. So you can see how much more perfusion there is in a wound bed after using mist therapy for 10 minutes. The latest research on the mist has been on deep tissue injury and bed sores, and it is remarkable. So you start treating it as soon as you see the deep tissue injury, and within 48 hours, typically, it's gone. It's resolved. It doesn't go on into this breakdown of a stage 4 bed sore because it's cavitating below the tissue. It's increasing the blood flow in those areas where the blood flow was gone because of the pressure. So this is a really amazing thing. So this is a study that was done looking at limb preservation in a vascular center, and you can see that the healing rates were very good. And these are patients with pretty significant vascular disease, 63% versus 29% at 12 weeks, which is amazing. And this is, I noticed it got printed out, but I was just putting it up there to kind of toot my own horn, because we did a few studies, case reports, using the MIST machine with some of our vascular surgery patients in healing, and almost every single time we were able to achieve healing. So the next thing that's really been a great thing for wound healing is the biologic dressings, the skin substitutes. And on here you can see some of the ones that we have that we call biologic dressings, like Regranix, which has been around for a while. It's processed platelets. It's $700 for a tube this big, and it works okay. And there's some black box warning that it causes cancer. So nobody really uses a lot of Regranix anymore. The slide below that, the picture below that, is platelets. This is where we would draw the patient's blood and spin it down and draw off the platelet-rich plasma, mix it with thrombin, and drop it on the wound bed as a clot, and then cover that. And the theory was that the platelets were pure. They hadn't been processed, and that those unadulterated platelets would then stimulate, because the growth factors come primarily from the platelets. And by putting platelets directly on the wound bed, you could actually achieve healing. And you also get the fibronectin and other things that are in the plasma. It actually worked really well, but it never got FDA approval, because when they did the FDA approval, they kind of lumped it in with all the other platelet things, like Regranix, like Procuron, if you remember that, which was a processed platelet treatment that failed miserably and cost millions of dollars. And so they didn't ever approve it. And now it's kind of a moot point, because we have other dressings that work so much better. Dermagraft and Applegraft came out, and they were really great. But now we have placental tissue that we've been using quite a bit of. And, since the FDA approved it, and it now has an approval by Medicare, they're just coming out of the woodwork with people with all kinds of placental dressings. And we use in our clinic two kinds. We use Epifix, which is a dehydrated placental membrane with amnion and chorion, and we use Grafix, which has amnion or chorion, and it's a living cell tissue. Both of them have worked really well. They both have a lot of evidence behind them, and so even though there's a bazillion of them out there, those are the two we chose because it does have the evidence backing them. So amnion and chorion. The amnion is the layer that's next to the baby, next to the fetus. The amnion has to grow with the fetus and still provide all the nourishment that the baby needs. The chorion is next to the uterus. And the chorion is actually where all the growth factors and the cytokines come from. And both of these, the amnion and the chorion, are actually avascular tissue in the placental membrane. So this slide shows what is actually there in the tissue. And this is actually a slide from the epiphyx that shows what's available in the amnion and what factors are there in the chorion. And you can see there's a ton of stuff there. And you put this on and it interacts with the wound bed to supply what is needed to stimulate healing. What we don't know is, because we're using a dehydrated product versus a living tissue product, is there a difference? Does one work better than the other one? In our experience, not really. We don't really know that yet. And the other thing is, do we really know if you need amnion and chorion? Or do you just need amnion, or you just need chorion? So there's still so many things that we don't know about these products. So we're still big in the learning curve. So this is a slide looking at putting epiphyx on a diabetic foot ulcer, and you can see how much healing was actually achieved in 1 week in a diabetic foot ulcer versus standard of care. And standard of care is what you would normally put on a wound. It wasn't, just saline or something. Both were offloaded, all things were controlled, and this is what you see. And one of the things that happens in these placental grafts is that what they found in vitro is that it increases significantly the factors that help to stimulate angiogenesis, the VEGF, etc., is significantly increased in the graft. And in vitro, in the agar plate, they can actually measure that. And so the theory is that it works this well in diabetic foot ulcers because there is that perfusion issue. There is those microvascular disease that happens in diabetic foot ulcers, and maybe that's why this works so well in diabetic foot ulcers. Even in our clinic, you put them on a DFU and it works great. You put them on a venous ulcer, it works, but you don't see a change like this. So that's kind of the theory about why these products work so well on low perfusion ulcers like arterial insufficiency and diabetic foot ulcers. And here you see a slide again with epiphyx compared against Apligraf and Dermagraf in healing rates. And so Apligraf, was an incredible product when it came out. It was amazing. It healed itself in this little plate. It used to come fenestrated and they charged extra. And by the time it got you, it had healed itself. And so they figured that out. So they quit charging you for that because it didn't work. So it was a fabulous product. But now the technology is so much better. Now we have this new placental products that we still have a lot to learn, but they're really changing the way we do business. So this is a patient who arterial disease. She's an older patient. She had a trauma that really did a number on her. She had some significant disease. She had a couple angioplasty procedures, restored her flow. It was recommended that she have an amputation because she had exposed tendon here and they didn't think it was going to heal. But she refused because she still, lived alone and really needed her independence. Totally with it woman. So with standard wound care and some grafting, she actually healed this up. And she just turned, I think, 100 and something years old not too long ago. This was not necessarily a placental cell, but it shows that with actual, with good wound care and we use mist on her, using the technology that we have available, you can achieve healing in situations where otherwise it would have been an amputation. So because we're the Wound and Hyperbaric Center, I have to talk to you about hyperbaric oxygen. We have 4 chambers. We're the only accredited hyperbaric facility in New Mexico. We have treated all kinds of patients, but mostly we treat osteoradionecrosis. We treat soft tissue radiation. We treat lots and lots and lots of diabetic foot ulcers. We treat acute traumatic ischemia, compromised grafts and flaps. Not so much necrotizing infections because those patients are inpatient and we're an outpatient facility, so just the logistics of that is difficult. We do a lot of osteomyelitis, and we do treat ischemia caused by acute thrombosis and embolism. Patients with embolic disease, patients with frostbite do really, really well in hyperbarics. It really makes a big, big difference. So hyperbaric oxygen, this is the kind of chamber that we have. It's a big acrylic chamber. We have a TV with all the videos and cable and stuff you can watch. And how it works is it increases oxygen delivery to the tissues and reduces the ischemia reperfusion syndrome that happens frequently. It causes reduction of edema. It helps control bacteria in the wound bed. That's why it works well for anaerobic problems. It stimulates angiogenesis, fibroblast proliferation, and collagen synthesis. So if you need to treat for somebody, just let us know, send them down, we'll be glad to evaluate. And that's it. Are there any, well, let's hold questions for the panel. Thank you very much.